Good evening, everybody. Welcome. Thank you for joining us today. I'm Jennifer Sharp. I'm the chair of the College of Health Sciences Advisory Board. I'm delighted to have you all join us today. It looks like we have a great group who've decided to join us, so I'm thrilled that you're here. This is the second of a monthly webinar series presented by members of the advisory board. If you joined us for the inaugural session in October, you heard me say that this series is one of several activities that Dean Van Lunen, her team, and I have put in place to increase engagement between the board and faculty, staff, and students. So I'm very thrilled to have yet another webinar. The first one was fantastic, and I know this one is going to be fantastic as well. I do want to offer a thanks to Ashley Johnson and the ODU Office of Community Engagement for all of their support and assistance with today's webinar. Several of the team members are on the webinar behind the scenes today. And so thank you all for what you're doing to make this happen. I also want to thank Priyanka Patel, who is president of the Public Health Student Association at ODU, for agreeing to moderate and lead the Q&A portion of the presentation today. Priyanka is a second-year MPH student who will pursue her PhD beginning next summer. So welcome, and Priyanka, thank you. We're delighted to have you here as well. I am very pleased to introduce our speaker today. An environmental health officer in the U.S. Public Health Service, Lieutenant Commander James Speckhart, and I have worked together on the advisory board for the past 2 years. James is an ODU environmental health program graduate and is very active with the current program, as well as the National Environmental Health Association, where he serves as a regional vice president. I'll let James tell you a little bit more about himself. So without further ado, I will turn the microphone over to our distinguished speaker. James, thank you so much for being here with us today.
Well, thank you, Jennifer. I so much appreciate the opportunity to be here. And let me make sure I share my screen before I get started. That way everyone can see what's going on here. There we are. Okay. Want to make sure that the screen looks straight. First of all, thank you so much for the opportunity to guest present today. My name is James Speckhart, and I graduated from ODU back in 2005 with my MS in environmental health. I am an actual native of Virginia Beach and grew up in the area, and went to ODU for my master's. For several years now, I've actually been, working in public health and environmental health with the U.S. Public Health Service, and it's a great opportunity to be able to be part of this today, coming back to see you all and to present to the College of Health Sciences and all those who may be on the Zoom call today. So thank you to each of you who may be on this presentation today. Part of my journey with environmental health here on this presentation is sharing about my experience on the COVID call center hotline and what that means and what I experienced regarding that. As I continue on with my presentation, I'll be sharing a little bit more in context about my overall experience with the FDA's COVID call center. About half to 2/3 of the time I'll speak, which is about half hour, 45 minutes tops, we'll be highlighting my experiences on the call center. And then I have some resources I'd like to just thematically talk about towards the end of that time and allow for Q&A towards the end. As I start my presentation here, make sure it's advancing. Hold on a second. Make sure the presentation is advancing. Just a second here. Let me see what's going on. Let's see here. There we go. I have to hit the hard button. First of all, I'd like to say before I get started too far down the line, that even though this is going to be speaking about my experiences on the call center as a public health service officer, these views that I'm sharing do not represent the Department of Health and Human Services, FDA, or the U.S. Public Health Service, and that any errors, omissions, or misinterpretations are my responsibility alone. I just wanted to share some observations I had from my time on the call center. All right, so I wanted to give you a little bit of background about who I am. This is my wife, Kimberly. She and I met her in the Tidewater area several years ago. She's a clinical psychologist, and we have a lot of fun hanging out at the beach, as well as going apple picking. Those that may not recognize, the photo on the left is actually the Virginia Beach oceanfront. It's one of our favorite places to go towards the north end, and so we enjoy those times. And one of our favorite times to go for relaxation is apple picking. So what you see on the front there is actually us up at Carter Mountain Grove near Asheville. Carter Mountain Grove is actually a family-owned fruit orchard that actually you can get all kinds of fruit picking available year-round, depending on when you look on the calendar. But we enjoy being out there, and that's us kind of standing with the background. We actually had been apple picking earlier, so that's just a great view out in the background. And beautiful Blue Ridge. Okay, now part of my background here on what I'd like to talk about is kind of a bird's eye view with the overall experience I had in the call center. As I've given you the outline here, I'm going to be talking about what the purpose of the federal mission is, what some of the background was on the call center, kind of calls we had, some questions we had, and then dealing with response capacity of our public health system, and then discussing a little bit towards the end about health literacy and the importance of being very action and citizen engaged, and some resources. So this is going to be a very big bird's eye view. All right, so this is a bit of background about who I am. Background 2005, worked in the private sector for a few years, and then for the past 12 years, I've been with the Public Health Service, detailed to the Coast Guard, as well as with the U.S. Department of Agriculture, Food Inspection Service, as well as FDA. I've had various backgrounds, as you can see, and so with that being across 3 different agencies, about 12 years, I've been able to practice environmental health, industrial hygiene, and occupational safety during that time. And part of my tour actually brought me back to the Coast Guard in the Norfolk area. But currently, I'm actually at the U.S. Food and Drug Administration up in Silver Spring, Maryland, where I conduct biosafety environmental health support work for the 75 labs that we have at the BSL-2 level at the Silver Spring FDA main research campus, where the FDA commissioner has their office. In addition to the work I've done since I graduated from ODU, I'm also on the board of directors of the National Environmental Health Association, and I've been on that board since 2012, where I represent the Mid-Atlantic states on the board, including Uniformed Services, and also I help lead a ad hoc committee dealing with research and development. And of course, I've been a NEHA member since 2004, and of course with American Industrial Hygiene Association since 2008. This is the background of the U.S. Public Health Service. So for those that may not be aware of the Public Health Service, it is one of the 7 uniformed services of the federal government. Of the 7 uniformed services, you have DOD, then you have NOAA, National Oceanic Atmospheric Administration, but one of the lesser known but no less important services is the U.S. Public Health Service. We were founded through the Seaman and Merchant Health Care Act of 1798. We're formalized as a commissioned corps in 1889, and of course our category has existed since 1943. I'm trying to make sure that let me see if I can get, there we go. That way you can see the full screen there. Sorry about that. So you have the Public Health Service, 1798. We're formalized as a Commission Corps in 1889, and of course our environmental health category. These are the since 1943. This represents all of the highlights, the categories of things that we cover in the environmental officer category. For those that may not know, we have a history of coins that we have in the uniformed services, and this is the front and back of what our general service coin is, and this is the main side of our category coin from the environmental health officer category. In addition, we have the U.S. Public Health Service leadership, which is Admiral Brent Garrar, who you may be familiar with, him being in the news, as well as our Surgeon General, Vice Admiral Jerome Adams. I report to these two individuals. In addition, the Public Health Service, we have 6,000 active duty officers across 11 professional categories. As you can see here, we have a number of very proud categories showcased, including environmental health officer category. With the Public Health Service, we respond to all kinds of public health emergencies, reaching out to underserved and underrepresented communities. And of course, the ASH, or the Assistant Secretary of Health, and the Surgeon General are the two principals that head up the U.S. Public Health Service. And of course, I am reporting to them ultimately. What I'd like to talk about in general with our presentation will be more of a systems approach, kind of taking a Venn diagram as it relates to public health issues and COVID. This picture is representative of a kind of call center experience. Just to give you a little context, this was not the actual call center I was at. We actually had a room at one of the buildings on the FDA research campus that was about this size, but we were spread over many, many feet. So we're not this close together because obviously we needed some space for safe operation as well as safe distance, reasonable social distancing. After actually about 2 or 3 weeks working at the call center, we actually ended up all working remote. So as I said, this is only a representative, but this is where there's other PHS officers who are in response for other circumstances as well. And so this is representative of what a call center could look like. All right, to give you a little more context, when we were with the FDA's COVID response and their mission, for those that do not know, the FDA mission as related to COVID was multi-tiered. We actually had FDA's mission involved emergency use authorization, which is currently in the news. It is very important to recognize that, you know, we were dealing with a spectrum of circumstances with COVID. And in addition to what I want to share here, I did also want to say to those who have had any kind of loved ones or other impacted by COVID, I'm very sorry for those circumstances. And I hope that everyone has a good recovery from any COVID related experiences that they have had with a friend, loved one, or other relative. I can tell you from the standpoint of emergency use authorizations that we dealt with a variety of circumstances surrounding the FDA mission as it relates to the regulated side of COVID. With emergency use authorizations that are still ongoing, we answered questions at the call center as it related to diagnostic test kits, CLIA, which is the clinical laboratory analytical process. We did not deal with CLIA or CLIA waivers at FDA. That is something that's dealt with at CMS, Center for Medicaid and Medicare Services. So we usually made a point of letting people know of where the resources were with CLIA at the state level, at the federal level, to deal with that issue. Likewise with the applied labs, with the state consolidated labs, anything with PPE as related to masks, gloves, or coveralls. any kind of, we are issued letters of authorization as authorizations were submitted appropriately to FDA. In addition, any issues with automated ventilators or face shields that had to be authorized by FDA, all those were submitted to FDA for appropriate review. We also had guidance policies as it relates to these same topics. One interesting thing to come out of the PPE aspect was when we were receiving inquiries from the public about certificates of approval, et cetera, it turned out that there was actually issues that were, or certificates that people were thinking were authorized by FDA, but in fact, any certificates that we were receiving were actually fake because FDA doesn't issue any kind of certificates of approval. We came across this issue very early on in our time with the call center. And so that became something we had to monitor very carefully. Just to go by the numbers here, to give you some broader context. In the 4 months we operated from mid-March to mid-July, we answered at least 20,000 calls. That doesn't necessarily include the emails and follow-up calls we made from all 50 states. I myself answered a little over 1,000 calls during around that same time period. I worked a call shift from mid-evening to early morning. We were fortunate to have about 25 officers who reported to the team. They included the categories that are listed there, including environmental health. I'd like to point out that I was actually the only environmental health officer by category on the call center. So I had a very unique experience as an environmental health, industrial hygienist, occupation safety health officer to actually answer the various calls that I took during the time I was active on the call center. To bring that perspective to any of the callers and even giving some feedback to my fellow officers and other civilians. And we did have a handful of civilians answering calls for us during the second half of our time on the call center. So I will say from the standpoint of the call center experience itself, it was life-changing. It was something that you never really get prepared for, but that you try to respond as best you can, knowing that you have people who are very distressed, very, not sure what to do because of, well, it's not like we planned for a pandemic. And in terms of, last pandemic was 100 years ago. So it was challenged to see how do we bring together this information? How do we relay what FDA is doing about the federal response to the pandemic and how we can bring answers and solutions and reassurance to the public because they're looking to us for guidance and for feedback. Some of the general observations I made during my time on the call center included being culturally aware, being competent and sensitive to those who may be contacting us, and being sensitive to what their needs are, because there's a lot of people who are scared, upset, not sure what to do, and we had to give them that feedback. In addition, I was able to use my bilingual Spanish skills to a certain extent on callers from a couple of states that I have listed here. Basically, East Coast, West Coast, and Southern US, and some from Puerto Rico. I did actually also take calls from other countries. This was representative of some of the countries that I experienced, and they would call on the main 800 number, they would call via Skype on the phone, and it was just very interesting having an experience to talk with individuals who were trying to submit emergency use authorizations. They were concerned about a family member, relative, they themselves may have been impacted. I can share of one unique experience I had, actually, someone calling from Bolivia. They were actually a native of one of the US states, and they were actually in Bolivia on vacation, and they got stranded there because of the travel restrictions. And so they wanted information about, was it safe to travel? What kind of information could they get from the local health authorities? I ended up pointing them to the CDC and the Pan American Health Organization for resources. I actually gave them certain websites directly and gave them guidance to the contact in their country that would be helpful to them. But many of the other callers were people who were trying to get their products reviewed by FDA, trying to get feedback about what steps they should be taking. Probably one of the biggest challenges I had was trying to give to the folks seeking the emergency use authorization, which is FDA's very rapid turnaround time on reviewing material or items that were regulated by FDA, giving them reassurance that FDA's review team is looking at every application as quickly as they can. Probably one of the biggest frustrations I had was dealing with the individuals who wanted a specific time frame from FDA about their EUA being approved. Well, we couldn't give that at the call center because we had to dedicate all of our time on the call center to answering calls. The review team at FDA was a whole separate set of individuals, and all's their job, their role was to review EUA applications across the categories that I mentioned earlier, showed you earlier on the presentation. That there were dozens of people just looking at EUAs for the various categories of things that I showed you. Diagnostic test kits was the primary thing, but PPE and other related items, all of those had to be carefully evaluated by the review teams. And then we pointed the callers back to the FDA's website where they could look at all this. I didn't put up the FDA's website related to the materials we were covering, mostly because I didn't want there to be any in-depth sidetrack from what may be on the FDA website. But the FDA.gov, the emergency use authorization about COVID, and all those details are there. So extensive website information that you can certainly look at on your own to get context for what I'm sharing here. To give you a sense of the kinds of calls that we had, included EUA approvals, the customer service response times. We had some, answering questions about, well, when will PPE be available domestically? We cannot even recommend what kind of, where people could get their PPE because FDA, our role and our regulatory authority is looking at reviewing items that have to be regulated by FDA for future approval. But for example, where do we get the PPE? We had to refer people to outside sources that are on the open market because we just didn't have the capacity to let people know where it was. And by agency mandate, we cannot endorse one particular vendor over another. So we had a very narrow pathway we could take. So we could say, there's 3M, there's any number of, various medical providers that would probably have PPE, including the home improvement stores. So that was part of it. In addition, many of the calls we took were dealing with telemedicine or basic public health, many people who didn't have any insurance. And really, in many ways, we were a mental health provider for people calling FDA because people were scared. We wanted to give them as much reassurance as we could so that when it came time for the actual information they were seeking out, we could be that listening ear, that sensitive, caring health professional on the other end of the line, giving folks reassurance that why they're calling us is very important and that we value them calling us for the help that they're seeking from us. We did have to guide people to say, look, this is what FDA does versus what CDC's role is, because FDA regulates, but CDC's role is to educate and recommend. So when we were trying to give information about PPE or anything related to COVID symptoms, we would, tell you what the FDA can do in terms of regulations, but many of my calls, I actually referred back to the CDC website and tried to walk people through what they should be looking for. And a certain number of calls that I received were dealing with research, development, and innovation as related to people who had a novel, potentially patent-worthy idea for something dealing with COVID, whether it was a hand sanitizer or a certain PPE they wanted to develop. So I was able to take kind of my environmental health, occupational safety, industrial hygiene hat and help them, guide them. And there is a website email address that they could submit their ideas to for review by a separate individual, a group at FDA. In addition to the experiences I had with helping that concerned parent or loved one of an individual who had maybe exposure to COVID or was concerned that maybe they needed to get a test, having that emergency operations center kind of mindset to really advocate for health literacy and reassuring the caller and having good emotional intelligence was really key from the very first hour that I was on the call center. I can tell you that my first call on noon on Friday, March 13th was actually a person who called from a certain US state and reassuring them that their symptoms, that they could get the attention they need if they needed to go to their local hospital or certainly check out the CDC website for their health needs. I would say that part of who called us were some individuals who were worried well. It's kind of a thing to consider. These individuals may call us more than once, and we just had to reassure them. That first call that I received, that person called back probably 4 times that same afternoon, and we were able to try to give them as much reassurance as we could. But that was a profile of an individual who we just wanted to reassure. So the spectrum of individuals who called from all 50 states and even some overseas countries who were concerned about their well-being, we just had to provide them reassurance that we were going to try to give them as much help as we could. And that knowing that each caller had a reasonable question, they had good decision-making, we just want to empower them to feel like they could kind of go the next steps with whatever we needed to share with them. In addition, we had a certain number of callers who were very obviously upset with the federal government and with the FDA or some element of the federal government dealing with COVID. We just had to, we would, in some cases, try to reassure them, but sometimes it was just a matter of listening for a certain period of time, note that they were calling and note their concerns. And in a number of the cases with these upset individuals, there was nothing we could say or do that was going to change their mindset. They just had to let their hard feelings be known, and we were there to try to help them and support them, be an active listener. And then eventually those callers, those calls were handled as they needed to be. Some of the specific health questions we encountered with the COVID hotline included these, understanding the role of what FDA's mission was versus CDC, the technology issues. We had circumstances where understanding what's on the website, trying to access the government health information on your mobile device versus a tablet. One of the things we definitely experienced was having issues with people not being able to access the website fully by their phone. You had to actually go to the web because it was a certain amount. There's just a lot of information on the FDA website versus CDC, but since they're calling the FDA, we had to relay, hey, this is what's on the FDA website, and it's really best viewed through a laptop. And we tried to guide people, saying, look, if you can't see what we're seeing because of screen limitations, then you're going to have to try to get to a laptop or view it on a tablet, and kind of go from there. Other issues related to just getting people to a healthcare facility and that they could call. And I had many a person who I asked them, what's your zip code in your city? Where do you know about the nearest hospital to you? I'd look it up. Hey, what's the street address for the nearest hospital that you're by? I actually would give them the phone number for the hospital and make sure that they were comfortable with getting the healthcare advice that they needed if they did not have a personal family physician, or if they at least needed an immediate answer. In some cases, I'd make sure that they thought they needed to call 911, that they made sure they did that. In addition, making sure they got tested through the appropriate location, telling them that the COVID test is going to be covered by your insurance more than likely, and it's important that you ask that question. Any test results that they were getting, we could not interpret any test results. So we had to make sure that they understood that we had limitations legally, that they needed to talk to a qualified medical person to get that feedback, and we went from there. In addition, we had to have some challenging conversations with individuals about the certificates of approval, because even though people were seeing these things provided to them or secured by them, that these certificates of approval were actually fake, and that those were misleading communications that people were getting. So we're trying to make sure folks were getting the authorized communication from FDA in the form of a letter of authorization, which is on FDA letterhead. FDA always communicates with formal legal communication on letterhead, not with certificates of any sort. That's bogus. This was the 3 binders I built up over 4 months. Quite the experience with the call center. I made those up for representing my experience. What I wanted to also drive home with my COVID experience, in addition to it being very profound and very life-changing, in that the call center itself reminded me of what is the federal government response capacity about COVID. And in that regard, I realized I wanted to bring out some numbers that would hopefully give some context to what I thought was contextual for the COVID response. The Public Health Service, we have about 6,000 officers in our rough budget. The numbers that are on this page are pretty self-explanatory, but thematically what I wanted to share was that when I look at the entire population, there's about 320 million Americans. Millions of Americans have obviously been impacted by COVID. There's roughly 240,000 people who have passed away from COVID. When I look at how many total people work in the federal government who are charged in some way with potentially responding to COVID, I look at their 6,000 officers, 75% or 3/4 of our officer staff have been deployed one or more times since March. Roughly 4,500 officers have been deployed across the country. And just to give you context, when that first cruise ship went into port in January, a PHS strike team responded to that cruise ship to help out all the passengers on there. When the first cases came to be known in the US at that senior care facility in Washington State, a PHS response team was there as well. PHS officers have been stationed at many of the federal medical facilities around the country since the beginning, and we continue to be, not only up in DC, but around the country. To give you further context, there's roughly about 1.5 million people who are active duty in uniform across DoD, within the Army and Navy and other branch services, who've been responding to various COVID response locations across many hospitals and other expanded care facilities. DoD's been, but what I'm getting at here is that when I look at the number of Americans total are in the US, relative number of us who are capable of responding across the federal agencies, including the DoD, and you look at the relative budget that we have for public health response, the numbers tell a larger story. As I said, the numbers are pretty representative here. I could talk for an extended period of time about these numbers, but I won't, because I think they give you a sense of the amount of officer capacity relative to the number of people we're serving. It's a small percentage of qualified public health professionals, including civilians that work in the federal health system, not just officers, but the majority of the civilians who are working at the federal level alone, much less what's at the state level or local level. But at the federal level, we are at max capacity with our efforts. Many of the work challenges that we have that I see from this whole experience relates to there is a general lack of awareness of the federal health mission serving the American people. As I indicated, CDC, FDA, and OSHA have unique responsibilities by federal law. I will say generically that a number of the callers that I experienced were not aware of the role that FDA plays in their life. On a very, very basic level, a lot of folks, I think, when they called us, didn't realize that FDA was more than just letters in the alphabet. The fact that we've been around for many decades doing applied public health work. So in addition to a lack of understanding of what the federal health system does in people's everyday lives, I also saw some indication of some reading and comprehension challenges with the US population, with understanding the various websites and how they're presented. So there was a lot of conversation about that with the people that were calling us and walking them through the information they were seeing. But our COVID call center response made me realize that our public health capacity in this country is very stressed, understaffed, and long-term underfunded. And there needs to be a larger conversation down the road about how we address that. And of course, that goes back to, how we as an American population what we expect of our public health system at the federal, state, and local level. In addition, with us being understaffed, there's a retirement trend going on in our country. Looking at people in leadership and in field practice, between now and the next 5 years, there's a significant change going on in our country. Towards that larger set about public health literacy, and this is a larger drive home message, was we want to better understand about how we learn, what we learn, and how we can take our actions and behaviors and change them to better things to come. Generically, I did some research, and it seemed to indicate that the average reading level in the US is only about upper middle school grade level, at about age 12 to 14. When we look at how we're learning and how we're understanding, there's definitely some challenges that we have in our country that we as a whole have to really seriously look at. When we look at, for example, how we learn and the fact that, the ways in which we learn, as is indicated here, that a good portion of how we can act on what we learn and understand is having a certain reading level comprehension. And what I could estimate was that the CDC reading level is at about a 9th grade reading level. So the CDC's website is about in line with what the average US population, adult reading population is. I came to observe that the FDA and NIH websites a little higher reading level. And so that would add to the challenge of maybe understanding the information that's on the website. OSHA is about the same way from what I could observe. So really, we have to have a larger conversation, I believe, about what health information is out there, how it's learned, and what we learn and how we put that into action towards behavior change. Also bear in mind that these observations I'm making did not occur because of COVID. I believe that COVID has actually made the circumstances more profound and more urgent for us to act upon. So really what I see here is a larger issue of maybe Hollywood and the movies coming into play here, where Houston, we may have a little bit of a problem with regarding literacy in our country as it relates to health literacy, and seeing how we each play a role in terms of better understanding where we can go with those, with these principles and themes that we believe to be the case. And so what I'd like to talk about during the last bit here, last maybe 5 to 10 minutes, is to give you a kind of a sense of the call center experience I had was very profound. We have a population that's dealing with COVID that's very significant, impacted, and we want to make sure we can bring about resources that are very helpful. And in this case, we have federal government resources with the FDA, with vaccines, with medicine labels, all that are part of the COVID response. We've got CDC's website with various public health communication. And I will say that CDC, in my view, does kind of set the gold standard for health information, health communication with the use of infographics, with easy to follow website information, downloadable documents. FDA certainly, even though I work for them, has a lot of good information on there, but it's important to know that, because my observations are that the CDC website seems to have a really good approach to what information is being shared, that the FDA website, the HHS website, all of them have good information, but it's certainly, every bit more they can make the information more user-friendly, more able to be comprehended for action and for behavior change on the part of not only the US population, but also those who are overseas who are viewing the CDC website, because the US does look to us there are many people who look to the US for guidance on what next steps to take, since COVID is a global pandemic. In addition to the FDA and CDC's information, there are strategic plans that HHS has about how it can communicate about the various things that HHS does. These subsequent resource slides, which I'm just going to briefly walk through, what I'd like to highlight is the fact is CDC has some great tools in its toolbox about how things are communicated with infographics, the relevance of health literacy. There are video profiles about the people who work at CDC doing great things. There's a great profile page about the 1918 pandemic, which I would highly recommend, that was actually created in 2018 on the 100th year anniversary of the last pandemic, and the importance of systems thinking as it relates to how we deal with public health. Other resources at FDA and HHS are other profiles of people who work here, the communications plan that's out there. And for those that might want to know, that there is a series of podcasts that HHS has about some of the key leadership at HHS, and a person in the PI in the media affairs office interviewed some key leaders at HHS, which you might find of interest. In addition to the Public Health Service, I will tell you that we've all been working diligently since the beginning of this pandemic to be responsive to the American population, and working at the various locations across the US, and even this evening, as I give this presentation, there are PHS people who are continue to work, and we will be deployed until the pandemic is been declared over, but that is not in the foreseeable future. I will say that PHS is recruiting for all categories of officers, including we have a newly authorized Ready Reserve, similar to the other uniformed services that have their own Ready Reserve. PHS is accepting applications. If you do not want to be active duty, then if you think that maybe being a Ready Reserve commissioned officer would be an option, certainly encourage you to explore that option. In addition, the Surgeon General's website has some great information. Continuing on, obviously DoD has a lot of resources they have out there about, from what they have done and continue to do, all the National Guard that are deployed on the state level. Resources at the state level, State Health Department, great infographic. There's a Medical Reserve Corps. I know that some folks at ODU and as students may be connected with the Medical Reserve Corps. And so that certainly is something where you can volunteer and support the local health department. You can look into that as you believe that would be helpful. In addition to the side of public health literacy that I wanted to emphasize at the state level was the science standards of learning. You can look at the resources and see what science topics, health topics are usually taught in the K-12 school system to get an idea of, well, what are middle school, high school kids being taught, or what are they supposed to be learning to better understand about science and health as they go through, so they can be informed about, how to act appropriately even at that age, beyond what is being taught in the, what's being communicated by the government resources. In addition, there's a number of non-government groups. This is not an exhaustive list, but there are private association groups and other associations that will, be available, that can share things about science and health that might inform the audience. I like to point out the Boy Scouts have the 134 merit badges. There's at least a dozen merit badges that could highlight about the importance of various science and health topics. There's actually a public health merit badge, which I actually taught in the past as a volunteer. And I would encourage, those of you to consider that. Other non-government resources, addressing mental health. There's a profound need for mental health topics and interventions in this country as it relates to COVID because of people being kept inside, et cetera, people worried about their loved ones. General public health literacy outreach that one could consider to look at to get a better context as to how do we measure our literacy or others' literacy, and how do we communicate that to those who may struggle in that regard and need some encouragement and some empowerment. In addition, there's some great resources on the documentary side. These are some representative media outlets that have documentaries going on about COVID or about science and health. And I would recommend some of these resources here that are listed that I found helpful. Alan Alda is a well-known public figure for promoting health and science-related literacy through these platforms. I would encourage you to read up about it more. In addition, popular social media with the TED Med, YouTube, look at any of the keyword, any of these phrases into any of those platforms would certainly inform the population. And just some passing references. I will say that the environmental health publication here and the global health diseases books are very valuable publications. Final two take-home messages here to wrap up my efforts. So I appreciate your time. We have to really challenge our assumptions about thinking creatively outside the box, knowing that we all have roles to play to advocate for public health, to be science educators, set the standard for what people should understand and that we should advocate for the importance of having confidence and trust in our public health officials, that because we are trained and we have field experience. We have to be mindful about engaging our communities of color who are represented and underserved, mental health wellness as a whole, and how do we manage our social isolation. So knowing what are the resources you trust and why do you trust them, how do we be relevant, and being aware of the PHS opportunities that may be out there. Thank you so much for your time, and let's just make sure we continue and carry on the conversation, that we connect, communicate, collaborate, and change. I thank you so much.
Thank you, James. That was really very informative presentation. Now we will open a Q&A session. If anyone of you have a question, we have a Q&A box. You can type your question, or you can raise hand if you would like to ask your question and have a direct interaction with James. You can do so. All right, so James, we have a couple questions already, and I'm going to start. Yep. The first question we have from Hira Nadeem. She is asking, what department is the public PHS under, and is it FDA?
Actually, the U.S. Public Health Service is under the Federal Health and Human Services Department. So actually, our paycheck comes from federal HHS, and that's been the case from the very beginning. So we're under the Federal Department of Health and Human Services.